Hey everyone, it's Matt Kinney again, back with the final lecture on the surgery section of your Step 2 CK exam. The topic of this lecture is orthopedic surgery. Like the other surgical subspecialties that we've covered in previous lectures, the test makers generally don't focus on orthopedics, but the handful of questions you will receive tend to be recycled from test to test and year to year, so knowing this information cold will turn into easy points on your exam. We will start by talking about the different types of fractures and then move on to other orthopedic injuries. Fracture care is one of the most heavily covered topics in ortho because physicians in nearly all medical fields will encounter patients with acute fractures and must know how to diagnose and treat them. Thus, Kaplan has created the following graphic decision tree to help work through fracture cases. On your Step 2 CK exam, any patient with any type of fracture will likely present with the classic symptoms of pain, swelling, and in many cases, there will be a notable bony deformity on exam. If you aren't sure if the presentation is describing a fracture, consider the time course of the injury. While many orthopedic injuries can cause chronic pain and swelling, if there is an acute onset associated with trauma, you should immediately assume fracture and move on to answering the question. If asked about the diagnostic workup, an X-ray is always indicated for these patients, but you also must do a thorough physical exam and evaluate the nerves and arteries distal to the fracture site. The reason for this is simple. Nerves and vessels travel on or near bone and thus are at risk of laceration during fracture. As I discuss specific fracture patterns, I'll be sure to mention the associated structures at risk, but a thorough neurovascular exam is always a good answer when working up a fracture. If the question stem is looking for the best management option, you must first consider the specific type of fracture present. The most basic fracture classification is open versus closed. Closed fractures are defined as a fracture that does not compromise the skin. These are clean injuries and thus do not need to be dealt with emergently. Management of these injuries depends on the alignment of the bone. If the fracture is well aligned, simple casting, also known as closed reduction, is sufficient. However, if there is a notable deformity on X-ray, or if the bone is comminuted, meaning there are multiple bone fragments present, a surgical intervention known as open reduction and internal fixation needs to be performed. If you are asked which management option is best, the test creators will make it wildly obvious on an X-ray whether they are looking for open or closed reduction. Open fractures occur when the skin is punctured. These are much more serious injuries due to the risk of bone and soft tissue infection and thus require an emergency surgery to wash out the injury in a procedure that is known as an irrigation and debridement. Be careful on these questions, as the test may try to trick you by offering antibiotics as the treatment option of choice. Antibiotics may help secondarily, but the correct answer is always emergent surgery. While your Step 2 CK exam will not expect you to remember all of the different fracture types you may have learned in your pathology courses, there are a few that continually show up on the exam. The first of which is a stress fracture, which occurs due to repetitive stress to bone. The question stem usually will describe a high-level athlete, often a marathoner, with pain in either the foot or around the knee. Unlike all other fractures, these injuries can be chronic and nagging and thus don't fit the classic fracture presentation. They also can't be diagnosed via X-ray, which is not sensitive enough to pick up the microscopic bone damage. So if asked about the diagnostic test of choice in these patients, look for CT or MRI. And the first-line treatment is cessation of activity and physical therapy rehabilitation, as opposed to surgery or casting. Compression fractures occur in the vertebral bodies of patients with osteoporosis, so look for the classic scenario of an elderly patient who presents with acute onset back pain, often after a minimally traumatic event, such as lifting a heavy object or a ground-level fall. It is often very difficult for these elderly patients to describe or localize their pain, but on physical exam, you may elicit point tenderness over the fracture site with palpation of the spine. The location of the compression fractures is evenly split between the thoracic spine, the thoracolumbar spine, and the lumbar spine, Cervical vertebrae are rarely involved. Again, diagnosis requires radiographic evaluation. Note the wedge-shaped abnormality on the image to the right and the associated loss of vertebral height. This is the classic X-ray finding in a vertebral compression fracture. While it may be difficult to appreciate without a comparison film, there is also decreased bone density in all of the imaged vertebrae, consistent with osteopenia or osteoporosis. If X-ray findings are inconclusive, a CT scan is indicated to provide better visualization of the spine. Treatment for these injuries is controversial, so you will not be asked about management on your Step 2 exam. The final type of fracture we will discuss is pathological fracture, an overarching term that describes a fracture which occurs secondary to another disease, often metastatic cancer or multiple myeloma. As you learned in the endocrinology section, Paget's disease leads to creation of weak, brittle bone and can also predispose to pathologic fracture. If the test is trying to describe a pathologic fracture, they will have to give you hints in the question stem as to the identity of the primary disease. They will also describe a scenario in which a fracture occurs with very minimal trauma, such as a rib fracture after coughing or a tibial fracture after bumping a table. Diagnosis is made via X-ray, and the key here is that if they ask about the management of these patients, you not only have to treat the fracture itself, but also must go hunting for the primary disease. So look for serum or urine protein electrophoresis if you suspect multiple myeloma, or a CT of the abdomen and pelvis if you suspect prostate cancer. Let's now discuss some of the common causes of arm and shoulder pain covered on the test, starting with clavicle fractures. These are common injuries and frequently occur after trauma to the shoulder region, either via a fall or some sort of traumatic impact. Like all fractures, pain and swelling will occur locally, and the classic sign described is a misalignment of the proximal and distal portions of the clavicle that is palpable on physical exam. While diagnostic workup requires an X-ray, it is also vital to do a full neurovascular exam of the arm on the affected side, because the subclavian artery and brachial plexus run just deep to the clavicle and are often injured with clavicle fractures. As an aside, there is no need to rememorize the brachial plexus for this exam. It is very low yield, and you need that brain power for more important pearls. Treatment of the clavicle fracture requires a sling, unless, of course, it is an open fracture, in which case irrigation and debridement is always necessary. Shoulder dislocations are a great way to test your understanding of anatomy in a clinical setting, so the Step 2 CK test makers love to ask questions about them. Thus, the information on the next few slides is very high yield, and you should make sure you understand the mechanisms of shoulder dislocations, as well as the neighboring structures that may be injured. Most importantly, it is necessary to be able to differentiate between anterior and posterior shoulder dislocations. Anterior dislocations occur much more commonly than posterior injuries, and represent about 95% of all shoulder dislocations. This is because they are a result of common injuries such as simple falls and sports-related trauma. The question stem will often describe a patient with nonspecific pain and swelling in the shoulder region, and will specifically mention that the patient has their arm resting in an externally rotated position. This is a key exam finding which can help separate this condition from a posterior dislocation, as will be discussed shortly. Diagnosis may be obvious on exam, but these patients should always get an X-ray to confirm the diagnosis and to ensure that there are no fractures associated with the dislocation. The classic X-ray to the right reveals an empty glenoid fossa and an anteriorly displaced humeral head. In rare situations, an MRI may be warranted to evaluate structural shoulder damage. Along with confirming the anterior shoulder dislocation, you must also perform a careful neurovascular exam, because the axillary artery and nerve are sometimes involved with these injuries. Therefore, you must check distal pulses to ensure that the vasculature remains intact and test the patient's ability to abduct the affected arm, which requires a functional deltoid muscle that is innervated by the axillary nerve. Treatment of shoulder dislocations, both anterior and posterior, is the same and involves reduction of the dislocation followed by immobilization with a sling. Posterior dislocations are rare, comprising just 5% of shoulder dislocations, and classically are a result of either electric shocks or seizures. Along with the expected pain and swelling, these patients will present with their arm held in internal rotation. The reason for this is kind of interesting and is directly related to the mechanism of injury. Because muscle is electrically stimulated, both shocks and seizures result in universal muscle contraction. In the arm, the muscles that control internal rotation, most significantly that bodybuilding muscle, the pectoralis major, are much stronger than the external rotators. As a result, the humeral head gets dislodged posteriorly, and the arm ends up in internal rotation. Remember that patients with anterior shoulder dislocations hold their arm in external rotation, so even though both injuries cause severe shoulder pain and swelling, this finding can help differentiate the two on physical exam. Despite the differences in mechanism and presentation between anterior and posterior dislocations, the diagnostic workup is the same, as posterior dislocations must also be evaluated by X-ray. While you will not be expected to diagnose a posterior shoulder dislocation based on X-ray on your exam, the AP image to the right displays that the humeral head is overlapping the glenoid fossa, indicating posterior displacement of the humeral head. Again, MRI is rarely indicated, but may be warranted to evaluate ligamentous damage as a result of the dislocation. And again, treatment requires relocation of the shoulder followed by sling immobilization. Now, before we move on to discuss injuries of the forearm and hand, let's work through a clinical vignette. A young man has had 3 days of wrist pain after experiencing a fall. He has tenderness and swelling at the base of the thumb on the back of his hand, but no deformity is noted. His X-ray is shown on the following slide. What is the best next step in this patient's management? Is it A, reassurance, B, MRI scan, C, thumb spica casting, D, amputation, or E, open reduction and internal fixation? While the question stem never uses the classic buzzword, the injury described is a scaphoid fracture. Scaphoid fractures occur secondary to simple falls in which the patient attempts to brace against the fall with an outstretched hand. Often these patients don't seek treatment immediately, as was the case here, but when they do, they have pain and swelling over the dorsal aspect of the wrist, specifically located at the base of the thumb or the quote-unquote anatomic snuff box. Unfortunately, the test makers avoid the use of buzzwords, so you must know where the snuff box is located. The key to this question, and a frequently tested concept, is that scaphoid fractures often do not show up immediately on X-ray, as was the case here with this normal X-ray image, but must be treated anyway to decrease the risk of avascular necrosis of the scaphoid, a common complication of these injuries. Thus, all patients suspected of having scaphoid fractures are placed in splints or casts for 2 to 3 weeks, and then are asked to return for a new set of X-rays. Reassurance would not be appropriate in this patient, because he may in fact have a radiographically occult fracture that will require treatment. MRI scan is overkill at this point, and even if advanced imaging was indicated, CT scans are better than MRIs for detecting bony abnormalities. Amputation may be going a bit too far in this otherwise healthy patient with a relatively minor injury. Open reduction and internal fixation may be required at some point if this truly is a fracture, but it is too early to tell and thus too early to jump to surgery. Continuing with the theme of hand injuries, trigger finger is a very common idiopathic condition that results from inflammation of a fibrous band in the finger that acts as a pulley for the flexor tendon of the digit. When this pulley system becomes inflamed, the flexor tendon cannot slide smoothly, leading to locking of the digit. As the name implies, the classic symptom is a lone digit which becomes stuck in flexion, as though it has pulled the trigger on a gun. Usually, the finger can be manually extended with help from the other hand, but as the finger releases, it makes a popping sound as the tendon snaps over the inflamed fibrous band. These patients also complain of pain in the digit. The diagnosis is made clinically based on the symptoms just described and does not require any additional imaging. Because inflammation is the underlying cause for trigger finger, a local corticosteroid injection is usually all that is required to quiet the inflammation and resolve the condition. Another condition that leads to undesired finger flexion is called Dupuytren's contracture. As you may remember from your dissection of the hand in anatomy, there is a fascial layer that covers the palm. In Dupuytren's contracture, this fascia becomes thickened into cord-like bands as depicted by the left arrow in the image, and these bands act to pull the digits into flexion. Unlike trigger finger, these digits are unable to be fully extended, even with the help of the other hand. Note that it is not the flexor tendon itself that is involved here, but rather an abnormality of the palmar fascia that causes the flexion contracture. While the pathophysiology of Dupuytren's contracture is poorly understood, there are several risk factors that predispose to this condition. Men are more likely to get contractures than women, and this is a progressive condition, so increasing age is a risk factor as well. Finally, there seems to be a genetic component to Dupuytren's contracture, and it classically affects patients of Northern European descent. Diagnosis is again based on clinical exam rather than labs or imaging, and treatment of this condition requires surgical resection of the fascial bands responsible for the flexion contracture. Recently, the FDA has approved a new injectable medication that may present an alternative for surgery, but until that drug is proven to be safe and effective, surgery is still the best choice on your Step 2 CK exam. Let's switch gears by tackling another case. An elderly man comes to his doctor with long-standing bilateral leg pain, which is worse when walking and better when sitting. Leaning forward also alleviates his pain. He does not smoke. What is the most appropriate next step in the diagnosis of this patient? A. Lower extremity x-rays. B. Doppler ultrasound of the calves. C. Ankle brachial index measurement. D. Spinal MRI. Or E. Leg MRI. This is one of those tricky Step 2 questions in which you have to narrow in on a specific diagnosis to correctly answer the question. In this case, the patient is suffering from pseudoclaudication, which is a symptom of spinal stenosis. While the patient's symptoms may sound a lot like claudication, with leg pain that is worse with exercise and better with rest, they also give you key pieces of information that should lead you away from claudication and towards spinal stenosis. First, the pain is equal bilaterally, which points to a spinal etiology rather than a vascular one. Furthermore, the pain is alleviated by leaning forward. Flexion of the spine opens the spinal canal and relieves nerve root compression. Leaning forward would not improve symptoms of vascular claudication. And finally, they make a point to mention that the patient is a non-smoker, which decreases the potential that this is true claudication. Once you settle on the correct diagnosis, you must then select the correct imaging modality, which in this case is a spine MRI. Lower extremity x-rays would be helpful to rule out a fracture, but not for chronic bilateral pain. Doppler helps to evaluate for deep vein thromboses, which does not fit this patient's symptoms. As discussed, this is not claudication, so ankle brachial indices would not be helpful. And this patient's pathology is in the spine, not the leg. Back pain is one of the most common causes for doctor visits in the United States today, and while many cases are nonspecific, there are a few key causes of back pain you should be familiar with on your Step 2 CK exam, the first of which is spinal stenosis. Spinal stenosis is a sequelae of osteoarthritis of the vertebrae, which leads to formation of pathologic bone called osteophytes, which narrow the spinal canal. Most frequently, spinal stenosis affects the lumbar spine and causes symptoms in the lower extremities, but it can originate in the cervical spine as well, leading to muscular pain and weakness in the arms. Symptoms include neck or back pain at the level of the stenotic canal, as well as dermatomal symptoms that result from nerve root compression. Since this compression is occurring within the spinal canal itself, as opposed to where the nerve root exits through the vertebrae. Symptoms are bilateral. As presented in the last case, the classic presentation is pseudoclaudication, or bilateral leg pain that seems to be worsened with exercise, but is actually worsened by the act of standing up and extending the back, which increases compression of the spinal nerve roots. When these patients sit down, or lean forward as they might if they were pushing a grocery cart, the associated flexion allows the spinal canal to widen and leads to symptomatic improvement. Diagnosis of spinal stenosis requires an MRI, which is the diagnostic test of choice anytime you want to evaluate the spinal cord itself. As the arrows on the image to the right depict, there is significant narrowing of the spinal canal in the lumbar spine, and you can imagine that this narrowing would lead to compression of the nerve roots and symptoms in the associated dermatomes. While definitive treatment of spinal stenosis requires surgical decompression of the spinal cord, often the patient's symptoms can be managed with non-steroidal painkillers, allowing the patient to avoid surgery. If asked about management of this condition, the test makers will make it blatantly obvious which of these two options they want you to select. Herniated disc disease is another cause of nerve root compression and back pain, but in this condition, it is the intervertebral disc that herniates dorsally, leading to compression of the nerve root as it is exiting the spinal canal between two vertebrae. Disc herniation frequently occurs after a patient attempts to lift a heavy object off the ground, and occurs more commonly in the elderly due to age-related changes in the intervertebral disc architecture. The classic symptom of a herniated disc is sciatica, a lightning-like or electric pain that shoots down the leg in a dermatomal distribution and is usually unilateral rather than bilateral. This schematic shows normal spinal architecture on the right and a herniated disc on the left. Tears in the outer part of the disc, also called the disc annulus and depicted here in the darker blue, occur during aging and allow the nucleus pulposus, depicted in the lighter blue, to herniate out through the tear and cause unilateral compression of the spinal nerve root, which here is depicted in purple. This compression leads to radicular type pain, which is often described as electric inequality. Diagnosis of herniated disc disease can usually be made with a simple physical exam maneuver called the straight leg raise, in which a patient lies flat on their back and the physician raises the affected leg. If this maneuver reproduces the patient's pain, the diagnosis of herniated disc disease can be made. However, advanced imaging may be warranted in certain circumstances, which will be discussed on the next slide. And again, MRI is the imaging modality of choice. The image to the right shows an MRI that reveals posterior herniation of the L5-S1 intervertebral disc. You can imagine that this would lead to compression of the nerve root exiting the spinal canal between those two vertebrae. Because this condition is so common, and because treatment is simple and non-invasive, the Step 2 test makers love to ask about the management of herniated disc disease. The key to management is to avoid surgery at all costs. These patients' symptoms will resolve in a matter of weeks without surgery, and thus there is no need to put them through a risky procedure such as a spinal decompression. Instead, pain control with non-steroidal anti-inflammatory drugs is the treatment of choice, and patients should be instructed to modify activity to avoid worsening their symptoms, but should remain mobile. In other words, these patients should under no circumstances be prescribed bed rest, which will definitely be one of the available answer choices if you get this question on your exam. Most of the time, patients presenting with back pain, especially lower back pain that does not fit either of the diagnoses just discussed, have mechanical pain such as mild paravertebral muscle strain or osteoarthritis, and in these cases, pain control is all that is necessary. However, there are situations in which back pain is the presenting symptom of something really terrible, like cancer or a deep-seated infection, and thus you must be aware of the red flag symptoms that should raise your suspicion that something more serious is going on. Most mechanical pain gets better with decreased activity, so if the pain is constant and does not fluctuate with changing levels of activity, you should start to be concerned. Night pain is a classic finding associated with malignancy. Even if the patient's pain is dull or seemingly minimal, anytime pain has been present for an extended period of time, it is worrisome, and you should use 6 weeks as your cutoff. Low back pain and fever is concerning for an abscess, and these patients require further workup as expanding abscesses can invade the spinal canal, leading to compression or spread of infection. Any new onset neurologic deficit associated with back pain is also a major red flag and must be addressed immediately, or the changes may become permanent. You should especially be on the lookout for cauda equina syndrome, or the loss of bowel and bladder control, as well as abnormal deep tendon reflexes. And finally, anytime a patient has a history of cancer, no matter how remote, you must be worried about the reappearance of metastases. So if these patients develop back pain, they must get worked up as well. If a question stem mentions any of these red flags in association with back pain on your exam, you must be prepared to order imaging to rule out a mass lesion such as a tumor or an abscess. Again, MRI is the preferred test to evaluate the spinal cord and is the test of choice in this situation. Also, if a patient presents with the acute onset of neurologic deficits for any reason, including trauma, they should immediately be given glucocorticoid injection because steroids are proven to have moderate benefit in reducing the risk of permanent neurologic changes after spinal cord injury. We will now discuss 2 of the orthopedic emergencies you may encounter on your exam, and we'll introduce the first with a case. A young female pedestrian was struck by a car 3 days ago and suffered a femur fracture, which was repaired surgically. Today, she became confused and short of breath and is found to be hypoxemic. She also has a petechial rash. What is the most likely diagnosis in this patient? A. Myocardial infarction. B. Pancreatitis. C. Rhabdomyolysis. D. Fat embolism. While we will discuss the etiology and explain the presentation shortly, this patient has the classic triad of symptoms associated with fat embolism syndrome: confusion, dyspnea, and a petechial rash. Furthermore, she has recently fractured her femur, and fat embolism syndrome is a well-recognized sequelae of long bone fractures. An MI is unlikely in this reportedly healthy 22-year-old and would not explain the rash. Pancreatitis could lead to hypoxemia by causing secondary adult respiratory distress syndrome, but you would expect to see epigastric pain associated with her symptoms. Finally, rhabdomyolysis results from the rapid breakdown of skeletal muscle tissue after burns or crush injuries and would not be expected to cause hypoxemia. While there are few orthopedic conditions that are truly life-threatening, fat embolism syndrome is one of them, and thus you must understand the cause of this condition and be able to quickly diagnose it in your patients and on the exam. The precipitating event for fat embolism syndrome is high-energy trauma leading to a long bone fracture. Though the femur is classically involved, fat embolism is known to be a complication of tibial, humeral, and radial or ulnar bone fractures as well. The central medullary cavity of long bones contains fatty bone marrow, which is able to escape the bone after a fracture and enter into the bloodstream. Much like a blood clot, however, these fat vesicles are too large in diameter to pass through the smallest capillaries and thus become stuck, leading to vascular occlusion and poor perfusion of the tissues beyond the occlusion. The histologic section to the right demonstrates how the blood vessel becomes partially occluded by a fatty vesicle that arises from the marrow, and you can imagine that blood flow through this vessel is significantly obstructed. The symptoms of fat embolism syndrome are a direct result of decreased perfusion to certain organs and can be seen up to 5 days after the initial traumatic injury. Respiratory distress occurs with fat emboli for the same reason it does with venous thromboemboli. Blood flow to the pulmonary capillaries is blocked, and thus the alveoli of the lungs are ventilated but not perfused, leading to ventilation-perfusion mismatch and poor gas exchange, which will ultimately induce shortness of breath. And since they will be poorly oxygenating the blood, these patients will compensate by breathing faster. Confusion can be secondary to respiratory distress, but can also result from poor perfusion of brain tissue due to scattered fat emboli occluding the brain vasculature. And while confusion and shortness of breath can be nonspecific symptoms due to a variety of causes, the petechial rash is the true key to arriving at the diagnosis of fat embolism syndrome. The rash occurs for the same reason as the respiratory distress and confusion. Fat vesicles occlude the small capillaries within the skin, which causes these capillaries to rupture and bleed into the subcutaneous tissue, thus the appearance of small red dots spread across the skin. Petechiae are most commonly seen along the chest wall and in the arms, but can occur in the eyes, mouth, or anywhere else. While there is no gold standard diagnostic test for fat embolism syndrome, several lab studies will strongly point in that direction. Due to poor gas exchange, these patients will be hypoxemic, so you should expect the arterial blood gas to reveal a significantly decreased PO2. The reason the platelet count will be decreased on a CBC is that along with causing vessel occlusion, the fat vessels released from the marrow can also damage the vascular endothelium, uncovering clotting factors and leading to clotting and the consumption of platelets. Chest X-ray will show bilateral pulmonary infiltrates due to damage to the alveoli. And finally, urinalysis may reveal the presence of fat vesicles in the urine, a finding that is virtually pathognomonic for fat embolism syndrome on your exam. The true life-threatening aspect of fat embolism syndrome results from its ability to impair respiration, and thus management of this condition is keyed upon providing the patient with respiratory support and maintaining oxygen saturation, ideally above 90%. Supplemental oxygen is a must with this condition, and, if warranted, you must intubate and mechanically ventilate the patient to ensure appropriate oxygenation. The other commonly tested orthopedic emergency is compartment syndrome. Compartment syndrome can occur secondary to a number of different injuries. In theory, anything that causes swelling can serve as the precipitating event, though it is most often seen with fractures and burns, as well as crush injuries, which lead to a reflexive increase in blood flow after the crushing force has been removed. When swelling occurs in superficial structures such as the skin, it is able to expand outward, and there is no increase in the pressure experienced by the local tissues. However, the deep structures of the extremities are surrounded by a tight, fibrous fascial sheath which cannot expand. Thus, when swelling occurs within these compartments, there is no place for the fluid to escape, and pressure builds within the compartment. At this point, it should be noted that a hard cast placed on a broken bone can have this same effect if it is designed too tightly or placed before swelling has occurred. As the pressure builds in the closed compartment, it compresses the tissues found within that compartment, leading to damage of the local nerves, muscles, and blood vessels. In the worst-case scenario, compartment syndrome can lead to the dreaded Volkmann's ischemic contracture, in which blood flow is cut off to the muscles within the compartment, leading to the death of muscle tissue, which is then replaced by fibrous tissue that causes contractures of the distal structures. Limb loss and death can also result if the compartment pressure is not quickly relieved. The symptoms of compartment syndrome can be remembered with the 6 P's mnemonic. The earliest symptom, and the classic one you should be most familiar with for your Step 2 CK exam in association with this condition, is severe pain that may seem out of proportion to the injury and is especially noticeable if the muscles in the affected compartment are stretched, either actively by the patient or passively by the examiner. Pallor, or pale skin, is the second P and results from decreased blood flow through the affected compartment because the pressure buildup has partially compressed the blood vessels. The third and final early finding with compartment syndrome is paresthesias, the sensation of pins and needles beyond the affected compartment, which results from nerve compression. In severe cases, or cases when the diagnosis has been missed, the patient may experience the late findings of compartment syndrome, at which point treatment must be delivered as soon as possible to salvage the limb. The fourth P is poikilothermia, which is a fancy way of saying a cold limb and results from an even more severe decrease in blood flow to the point that the arm becomes cold. Paralysis, or the inability to use the muscles in the affected compartment, means that nerve damage has progressed beyond pins and needles and is now fully compromising nerve function. The final P of compartment syndrome is pulselessness, or the absence of a pulse distal to the compartment. This is an extremely concerning finding, as it means that the compartment pressure has surpassed the blood pressure and no blood is able to flow. At this point, ischemic damage has already begun. Treatment of compartment syndrome requires a surgical technique called a fasciotomy, which can be seen in the image to the right. In this procedure, surgical incisions are made and the fascial sheath is actually transected, which allows the pressure buildup within the compartment to dissipate into the superficial tissue and prevents further damage to the muscles, nerves, or vessels. The final orthopedic topic we will discuss in this lecture is the knee, and the common injuries to the knee you may see on your exam. Unfortunately, basically all injuries to the ligaments and soft tissues of the knee present with the same triad of symptoms: pain, swelling, and instability with certain types of movements. And thus, at times, they can be difficult to differentiate based on the patient's symptoms alone. Thus, you must pay close attention to other pieces of information given to you in the question stem. First, you must be aware of how soon after the injury the patient's symptoms developed. Was it instantaneous swelling or delayed swelling? Also, look for any clues that may provide information about how the injury happened. Was it a twisting injury, a traumatic sports injury, etc.? And finally, if the question stem does provide information about the physical exam results, look for the specific findings that are associated with each of the unique conditions we will talk about on the next slide. Regardless of what was injured, however, if you suspect some sort of injury to a ligament or meniscus within the knee, the diagnostic modality of choice is always MRI. This is a bit of a busy slide, but the information on it will allow you to quickly and accurately differentiate between types of knee injuries. And since this is a frequently tested concept on the Step 2 CK exam, I highly recommend that you know this information inside and out. The medial and lateral collateral ligaments are responsible for providing stability to the knee with side-to-side movement of the tibia on the femur. Injuries to these ligaments are often associated with sports and occur with blunt trauma to the opposite side of the knee, such as a football player being tackled from the side. Trauma to one side of the knee leads to stretching of the ligament on the contralateral side and can ultimately cause it to rupture. Swelling will immediately occur, and on exam, the knee will be unstable with side-to-side motion. However, these patients do not require surgery and can be treated initially with rest and immobilization, followed by physical therapy. Anterior cruciate ligament tears are also frequently associated with sports and can result either from direct trauma to the knee or as a result of a twisting injury, such as a basketball player landing with force on a twisted knee. Again, swelling will ensue immediately and will be even more severe compared to collateral ligament injuries. On exam, these patients will have a positive anterior drawer sign and a positive Lachman's test, both of which are positive when an anteriorly directed force applied to the tibia results in the tibia translating forward on the femur more than normal. ACL injuries require surgical repair, and at this point in time, the procedure of choice is an arthroscopic reconstruction of the ACL. Posterior cruciate ligament injuries result from forced hyperextension that may occur if a patient steps into a hole or a divot. Swelling will occur immediately, but will be mild compared to the swelling seen in ACL or MCL injuries. These patients will have a positive posterior drawer sign, which is effectively the reverse of an anterior drawer, and is positive if posteriorly directed pressure on the tibia leads to an abnormally large amount of posterior displacement of the tibia on the femur. Management of this condition is highly dependent on the patient, with high-level athletes usually opting for surgical repair and lay people often choosing rehab over surgery. The final soft tissue injury to the knee we will discuss is meniscal tears, which occur as a result of twisting mechanism of injury. With meniscal injuries, swelling is not immediate, but rather is delayed, sometimes up to 24 hours. There are also several physical exam findings that suggest a meniscal tear, including pain to palpation along the medial or lateral joint line of the knee, and a positive McMurray sign, which is knee pain when the tibia is externally rotated while the examiner places a medially directed force on the outside of the knee. Clicking and locking with knee flexion and extension are also classic findings of meniscal tears. Initial treatment of a meniscal tear does not require surgery. Let's finish this lecture with a case about knee injuries. A young hockey player experiences a traumatic leg injury, and he notes a popping sensation in his knee, which is followed by immediate swelling. An anterior drawer sign is present, as is medial knee instability, and the team doctor believes that the ACL and MCL are injured. What other structure is likely found to be injured on an MRI? A, the lateral collateral ligament, B, the lateral meniscus, C, the medial meniscus, or D, the posterior cruciate ligament. On step 2, it is rare that the test makers will ask anatomy questions, but when they do, they try to make them clinically relevant, as is seen in this case. This is the classic presentation of a so-called unhappy triad injury, which involves tears of the ACL, the MCL, and the medial meniscus. The key to remember here is that the medial collateral ligament is actually attached to the medial meniscus within the knee joint, and thus an MCL tear is likely to affect the medial meniscus as well. Conversely, the lateral collateral ligament and lateral meniscus are completely separate within the knee. In practice, injuries that include all three structures in the unhappy triad are relatively rare, but the test makers love to test your knowledge of knee anatomy with questions similar to this. Knowing that the ACL and MCL have already been injured, you would not expect an injury to any of the other answer choices, because each would have a different mechanism of injury. Okay, that's it for the surgery review for your Step 2 CK exam. All of the information we've discussed over the last 5 lectures has shown up over and over on Step 2, and will continue to do so in the future. So make sure to sit down and really learn this information, and it will definitely pay off when you get your scores back after the exam. Thanks for your attention, and good luck with the remainder of your exam preparation.